Welcome and good morning. Thank you for joining us for our live virtual MDA Engaged Community Education Seminar, where we will be highlighting specialists in the Mid-Atlantic area today. My name is Nicole Petrowski, and I'm the Community Education Specialist for MDA. We appreciate you joining us virtually today, and we hope you're all doing well. MDA is committed to community education, and we believe in the power of bringing our community together with educational opportunities able to hear from specialists throughout the country. This event is part of a larger MDA Engage series with disease-specific symposia, community education seminars such as this one, and community webinars as well. Our community education seminars, which are what we have today, are geared towards general neuromuscular disease topics. While each event will feature regional specialists, there are others that you can view on the screen that we are hosting for the remainder of the year. And as you can see, our last disease-specific symposium will be our SMA symposium on November 14th. We would not be able to put on our educational programming without the support of our generous sponsors. So I would like to thank New Motion Foundation, Biogen, and Genentech who have supported this seminar and this program. And I would also like to thank their representatives who are in attendance today. I have a few things to talk about, housekeeping items, before we begin. We are recording today's event, and we will be posting it to mda.org's website for on-demand viewing in just a few weeks. So if you have to hop away for a minute, or if you know someone who is unable to attend, we are recording it. Also, all of the phone lines have been muted. We will be having a Q&A session at the end of each presentation, so please utilize the Q&A icon to type in your questions. If you hover over the bottom of your screen, a tray of webinar icons will appear. Please click on the Q&A icon, and you can open that feature and enter your question to host. We also encourage participants to communicate with each other by utilizing the chat feature throughout the day. If you want to share a little bit of information about yourself or tell us where you're from, please go ahead and chat that in. You can chat to all panelists and attendees to make sure all the attendees see your comment. And you will notice in the agenda there are a few small breaks between speakers. Feel free to go get a drink of water or grab a bite to eat. This is the time when I'm going to be setting up the next presenter, so you will hear our microphones, just so you know. That's the time that I can check some audio. And then finally, we will be sending out a brief survey afterwards, and we would like to receive your feedback on what you heard today. We want to make sure we are discussing topics of interest, and your feedback is a way for us to improve these educational seminars moving forward. Now, it's my pleasure to introduce Dr. Terry Heiman-Patterson, who's the Professor of Neurology and Director of the MDA ALS Center of Hope at Temple University, Lewis Katz School of Medicine. Her career has been dedicated to clinical care and research in ALS. She does both basic and clinical research, and under her direction, the Center of Hope has conducted clinical trial testings, more than 25 experimental treatments. And while basic research is conducted using a mouse model to study genes that can modify the severity of the disease, as well as examine whether other novels can extend lifespan. So that's very interesting. Dr. Heiman-Patterson, I will turn it over to you.
Okay, thank you. Let me share my, are you sharing the screen?
You can share your screen now.
There we go. Can everybody see this?
Yes, we can.
Okay, well, welcome. This is really what I call the whirlwind tour, because so much is happening, and it's really very exciting. You know, I'm going to talk a little bit about all of the diseases, or just an overview of what MDA actually is devoted to and covers, and the diseases that that the Muscular Dystrophy Association has really developed their clinics to care for, and what they fund research on. And there are more than 40 diseases, so obviously I can't talk about all 40, but I'm going to talk about a few things. I'm going to talk about how we're developing tools to understand and treat disease better, and specifically the MOVR database that MDA is funding, talk about biomarkers, and some updates on how we do clinical trials and what's new about that will get us to the end goal faster. That is, finding medications and agents that modify disease and either cure or stop disease progression. And one of the most important areas is genetic manipulation. And you're going to hear a talk on genetics later, but I'm going to talk a little bit about how genetic manipulation is actually hit some home runs already, and really about the treatment revolution and update you on clinical trials. If I don't talk about your specific interest or disease, I'm sorry, I can only include so much in, whirlwind tour, and I'm going to highlight some of our sort of major advances. So, as I said, MDA supports research and care in more than 40 diseases. And it's really any disease that affects what we call in medicine the motor unit. And that includes the nerve cell as it comes out of the spinal cord and goes to send messages to muscle to move. And so that includes this motor nerve, as well as information coming back to the spinal cord about sensation and the junction between nerve and muscle, and then the muscle itself. And so we have diseases that include peripheral nerve and anterior horn cell, which is that motor nerve that comes out of the spinal cord. This includes things like spinal muscle atrophy, Charcot-Marie-Tooth, which is a hereditary neuropathy, ALS, and Friedreich's ataxia. Then there's diseases that really affect that communication region, what we call the neuromuscular junction, that connection between nerve and muscle. And the main ones, although there are others, are myasthenia gravis and Eaton Lambert. And then all of the muscle diseases. There are the muscle dystrophies, which include a host of genetic diseases that are inherited degenerative disorders of muscle, inflammation in the muscle, polymyositis, dermatomyositis, and also problems with the way muscle makes energy, what we call the metabolic myopathies. And these are problems with the way muscle uses sugars, fats, and burns them in a furnace we call mitochondria. And so there's a lot of things that MDA covers. And so starting with some of the advances, we have been developing tools that enable clinical research. And one of them is called the MOVR Data Hub. And as you can see, it's Neuromuscular Observational Research. And this is developed to really increase our ability to care and manage people who are living with these 40 diseases, and to help in developing clinical trials for new treatments. And the way it does that is modeling disease, so we know what the disease looks like and how it trends, and then we can develop trials that will show improvement in that trend or differences. And also it provides a source of people in some of the rarer diseases to find people with the disease so we can test new drugs. And, if you have a very rare disease, it's hard to find enough folks to try a new agent on. So this data set is going to help researchers get insights into how drugs and other treatments can affect outcomes. What are the outcomes, and how do they change with the treatment? And how can we better design trials? And I'm going to talk about a new kind of trial design that's come up that I think is really exciting and will accelerate finding new drugs. At least it's starting with ALS, and it's been used in cancer and other disease paradigms. We also, as I said, it'll help identify patients who could benefit from the new therapies and might want to participate in a clinical trial. And right now, this MOVR database includes people in the MDA clinic system who have ALS, Duchenne muscle dystrophy, and Becker's, facioscapulohumeral dystrophy, limb-girdle dystrophies, Pompe's, which is one of those metabolic diseases, and spinal muscle atrophy, which is a problem with that motor nerve as it comes out of the spinal cord. And so this is a growing database. The other advance and the other sort of push is in the development of biomarkers. A biomarker is really a measure of a biological state or a disease process. And so it can tell us something about diagnosis. It can track progression of disease. It may help to determine a mechanism. So that it could help stratify and target treatment to an appropriate disease population. And finally, it can tell us that the medicine got to where it was supposed to go and did what it was supposed to do. And so let me give you some examples. So a biomarker could be imaging. An MRI scan can show a stroke and can show improvement in a stroke. CT scans and PET scans. And what you see in the upper right is a PET scan that identifies inflammation. And so this shows an inflamed brain. All the red and yellow is where inflammation is. You can use this PET scan to look for inflammation of the brain in a disease process like ALS. You could also say, I have a drug that's going to attack inflammation in the brain, and I want to select a group of people who have that inflammation. So you could use it to select a population. You could also use biofluids. This would be blood, which contains white cells and DNA, and select people with a certain genetic abnormality to test or identify a certain genetic abnormality in a population with a disease. You can also look at it for concentrations of various substances. The best example is sugar in a diabetic. If the glucose is high, the diabetes isn't doing as well as if the glucose is controlled. So if I'm using a drug, I can both diagnose diabetes with a high blood sugar as well as track a treatment with how things are going with the blood sugars over time with a particular drug or pharmacologic agent. I can look at tissue, for instance, a muscle biopsy to diagnose, or a muscle biopsy to look, has been used in dystrophin research. In Duchenne muscle dystrophy, there's a lack of dystrophin. And some of the genetic treatments, we've actually looked for increased dystrophin in that muscle. That's a biomarker of effect of a pharmacologic agent. And these are critical to really identifying disease and tracking a treatment. And if we have a biomarker, we may be able to shorten the time of a clinical trial, because once we see an effect on our biomarker, we know the drug is working. We don't have to wait and look for instance, a survival endpoint or 2 years down the pike. And then there's other things you can use, like that EMG test that some of you have had, and breathing tests, clinical tests, and questionnaires. So biomarkers have been very important, and there's a huge push to develop them for diseases like ALS and other diseases. So when we do clinical trials, what is our goal? Not only is our goal to find a treatment that delays, stops, or reverses disease, but we need to show that it's a truly effective treatment. No snake oil here. We design trials so that we get the real answer, and we don't waste time getting to the real answer and waste money on treatments that aren't effective. And we want to make sure that the treatments are safe and side effects are minimized. And some of the challenges that we face are really targeting the treatment towards the mechanism. And so we have to understand the mechanism of disease so we can target the pathway to make a difference. We need biomarkers, as I pointed out, that maybe will help us shorten the duration of a trial and show us that something's effective before a long time into the treatment, and show us that we got where we needed to go, that the drug did what it was supposed to do, got where it needed to go, and did what it was supposed to do. And, we also have a challenge in making sure we choose the appropriate test population, especially when a disease has a lot of heterogeneity, a lot of differences between individuals who have the disease. That, for instance, is a major problem in amyotrophic lateral sclerosis. And we need to choose the appropriate endpoints. An endpoint is the objective of a clinical trial. Is it going to be survival? Is it going to be improvement in strength? Is it going to be improvement in a biomarker? And so the challenge is choosing the appropriate endpoint where we can really show efficacy. So, I wanted to give you this little introduction. And then, what are the phases of clinical trials? People get a little bit confused. But we actually have 3 phases of clinical trials before a drug typically goes for FDA approval. You have phase 1, where a few people are tested with a new drug. And this, by the way, takes place after years, 7 to 10 years of development in the lab and in animal models to make sure that it works in animal models, that it's not toxic to monkeys and lower mammals. And then you can first get to phase 1. And this is the first time you use a drug in people. And it usually works in healthy individuals, not people with disease. And we just look at safety and some dosage and side effects. We then do a larger study, generally on a group of people affected with the disease. And here we're looking for more side effects, more safety data, and a hint of efficacy. So we choose some endpoints that'll tell us whether the drug is modifying disease. And then the real efficacy study, the study that's really to look at, does this drug work, is phase 3. And so it tests the drug on a wider group of people affected with the disease, and it looks for long-term effectiveness, and that's your primary endpoint. And usually people are allowed to take any drugs that have already been approved for the disease, and it looks at more adverse events. And then you can go for FDA approval. That process takes 7 to 10 years. And that's why it takes so long to get a drug to market. And there have been some efforts at accelerating this, and in terms of approval and use of drugs that have shown no problems with adverse events in phase 2 and maybe some efficacy. There are some efforts to allow individuals to get to those drugs while phase 3 is going on, and this is expanded access type of programs. And then after FDA approval, generally there's additional testing to look for additional evidence, real world evidence of effectiveness and safety. So, how can we accelerate these? I just told you how long it takes. Well, there's a concept of a platform trial where there's one protocol. In other words, entry criteria are the same: who can come into the study, what is going to be measured during the study, and what the endpoints are going to be. And so this master protocol is applied to all the drugs in the platform trial, and you can test multiple drugs at once if the pharma agencies are willing to do that. And so you can see that in a conventional trial, you do one drug at a time, and it takes 7 to 10 years, and then you go to the next drug. In a platform trial, you actually, using this master protocol, can test anywhere up to, many drugs at once. And we're doing one in ALS where we're going to go up to 5 different pharmacologic agents. Since they all share the same master protocol, there's one placebo group, and for each sort of arm, each different drug, you have only a 20% chance of getting a sugar pill or a sugar injection or something that's not active drug, and everybody else gets drug. And so so that's of course a positive, because you have less chance of getting a placebo. And through the trial, it's adaptive, so you can drop those pharmacologic agents that don't appear to be effective if you do an interim analysis. It's more efficient. I'm doing 5 drugs over that time course instead of only 1 and then going to the next. And so this is sort of a new way to accelerate finding drugs that actually work and treatments that work. And so now I wanted to talk a little bit about genetics. And you're going to hear more about genetics later, but suffice it to say, for our discussion, this is really where our home runs are happening, and in some of the genetic illnesses. And so we have a set of chromosomes. We get half from our mom and half from our dad. And there are 22 chromosomes and an X and a Y, and the X and Y determine whether I'm a female or a male. If I have two X's, I'm a female. If I have an X and a Y, I'm a male. And I always get the Y from dad if I'm a male. And dad carries an X and a Y, so I can get either one, and that's going to determine my gender. In all the other chromosomes, there's two similar chromosomes, one from mom, one from dad. Each of those chromosomes is made up of DNA. And DNA is an alphabet. It's like alphabet soup. And the alphabet contains 4 different letters, or 4 different nucleotides, we call them, but they're basically, think of them as letters. And the sequence of those letters in the DNA determines how I'm going to put together amino acids. 3 of those letters code for 1 amino acid, and amino acids put together form a protein. So the chromosomes contain the blueprint for the proteins and how we put them together. And what can go wrong? And that's what happens sometimes. Here you can see in the left-hand side, the normal genetic sequence. Sometimes you can have a single change in those letters in that sentence. And so that change can result in, if you look on the right-hand side, you see sentences that are spelled out by letters, right? So DNA has all you can ask for. That's the normal. Well, there may be a change in that one letter, one nucleotide, and it doesn't make a difference. The sentence sounds the same. It's silent. DNA has all you can ask for. Or you can have a change that really makes it not sound right at all. DNA has all Lou can ask for. That's a misstatement, a missense. Or I may add in a letter that just stops the DNA altogether. That's a nonsense. That means that letter caused the DNA to stop replicating, stop making RNA to protein. And so we can now change the course of those abnormal genes, and we're going to talk about that in a moment. In addition, you may have a deletion or an addition, and in the 3rd and 4th level on the right, on the left-hand side, you can see where there's additional letters added, and in the lower depiction, there's a deletion of letters that should have been there, and that will change the whole downstream translation of the letters. Everything after the deletion or the addition is off. We call that a frame shift. That's the term used. But what it means is everything downstream is a mess, and you're not going to get a good protein. It's going to be rapidly degraded. And right now, we can change the course of things. We can manipulate the genetic material to treat disease. What you see in red are all the trials that are going on that alter genetic changes. We can deliver a gene that will nourish the nerves and improve the outcome, and that's being looked at in Charcot-Marie-Tooth. We can block the production of a gene that's become toxic because a change in that code made the protein damage the cell rather than help the cell. That's being done in ALS. In Duchenne, we can skip over where a portion of the DNA has been deleted and reestablish the DNA reading, overcome that frame shift. The 2 asterisks mean we already have drugs that are available for Duchenne that do just that and have shown improvement in the amount of dystrophin. We can also try to deliver a gene that can substitute for the missing gene or the damaged gene. And there's a program going on to deliver the dystrophin gene, a miniature version of it. We can block regions of toxic DNA where there's extra DNA. We can block the translation of that, and that's being attempted. We can also deliver a replacement gene, a totally new gene to replace the damaged gene, and that's being done in limb-girdle dystrophies. We can, again, block the abnormal DNA, that extra DNA and which creates extra RNA, and that's being done in oculopharyngeal dystrophy. And of course, another home run, we can change the way the DNA goes into RNA and the RNA makes protein. We call that changing the splicing, how RNA is put together to make the protein. That's hit a home run in SMA with nusinersen, and more recently, we have a second drug. And also we are delivering the normal gene with a viral vector, Zolgensma, and that, again, 2 home runs in spinal muscle atrophy. This is a reality. It's not just a dream anymore. And so let's go ahead and do some updates. Now that you have that background and you can see how exciting things are, genetic manipulation is really going to make a difference to the inherited diseases that MDA covers. So to start, I'm going to go through some diseases of nerve. Charcot-Marie-Tooth is a disease that affects the peripheral nerve, the motor nerves. And think of the nerve as a wire. There is a wire and insulation. When the insulation is damaged, we call that type 1. When the wire is damaged, that's type 2. And this causes progressive weakness and sensation changes in the legs. And we now have, there's more than 20 different genes that, when damaged, cause the disease. And so at least one of the clinical trials is really sending a gene to type 1, which is neurotrophic, meaning it's like nourishes that nerve cell to try to keep it from dying. There are several other clinical trials going on in Charcot-Marie-Tooth that are directed at other mechanisms of disease. In one case, ACE-083 is to promote muscle growth, and PXT2003 is a combination that is aimed towards decreasing the disability in Charcot-Marie-Tooth. Now, ALS, of course, is near and dear to my heart, as pointed out. This is the disease that I'm most active in or do the most clinical and basic research in. And this causes damage to the motor neuron system, which is a tag team of nerve cells, the upper motor neuron and the lower motor neuron. And these get messages from the brain all the way down the spinal cord. It's a tag team. That upper motor neuron brings the message down. It passes the message on to the lower motor neuron or anterior horn cell that brings messages to muscle to move. And remember, that's part of that motor unit that I pointed out at the beginning. And when there's damage to that upper and lower motor neuron, there's progressive weakness, thinning of the muscles, twitching, and a stiffness that occurs. And this is a fairly rapid disease, although it varies. And there's a huge difference among individuals with ALS. And it can present with arm or leg weakness or trouble swallowing, speaking. 10% of people have a familial variant, meaning there's other family members involved. And there are two genetic, there's more than 30 genes that have been identified as disease causing, but there are 2 that I want to talk about because, again, these are providing treatment strategies. The first gene ever identified to cause ALS was the SOD1. And the mutation in SOD1 makes SOD1 toxic. There is a toxic gain of function mutation. As a result, the strategy that's been used and is now being tested is blocking the production of SOD1 altogether. It's called Antisense, and that's in clinical trial right now, and we're up to phase 3. The C9ORF72 actually causes the vast majority of familial ALS, and is responsible for upwards of 40% of cases in families, and also up to 4 to 7% of people with out of the blue, no family history, but yet they have ALS. And in this case, there's an extra portion of DNA interspersed. It's called a repeat. And so we have that additional DNA inserted. And what's being done there is antisense, a strategy to block the extra DNA from being made into any kind of protein. And so if we look at treatment strategies in ALS, you can see in the lower right our gene modulation, blocking that abnormal SOD and blocking the extra material in the C9orf72. But we also have had some successes. In blue, you see those drugs that are already approved and have been tested. In green, you see the new Amylyx drug, which in phase 2 shows significant promise. There was some hint of efficacy in phase 2, and that will be going to phase 3, and that's a combination of drugs. In addition, we have stem cells, which are now, we should get a readout on the neuron stem cells sometime late in the year, because the trial has completed enrollment and data will be completed in October so that it can be analyzed. And the mechanism of stem cells appears to be anti-inflammatory. And what you see on this slide are all the different mechanisms, sort of bolded and enlarged, that have been implicated to play a role in ALS. So there's glutamate toxicity, there's apoptosis, which is programmed cell death, where the cell just dies, it's damaged. There's inflammation in the brain, there's oxidative stress, and there are genetic abnormalities. And each drug is directed at a particular pathway. And what you can see is really all in black, all the other drugs that are coming down the pike that we're going to be testing, and where they fit into our cascade of mechanism and what mechanisms they're directed at. But again, genetic manipulation is playing a huge role, and I think that I'm very excited about it and hope that it will show an effect on disease. Well, moving on to the next nerve, motor nerve disease, spinal muscle atrophy. This is a genetic disease. It's recessive in the SMN1 protein. And there's a decrease in the amount of that protein that's made or no protein made. And there are 3 variants: infantile, which before recently was pretty much uniformly fatal by the age of 2. Juvenile was the onset was a little bit older, and children would live maybe into their early teens or maybe only into the first decade. And then adult presentations. There's weakness that was progressive and breathing difficulties. And before, we would just have supportive care. But this is where things have really changed. We now have genetic modulation, and that's in the form of gene replacement, Zolgensma, and alternative splicing. It turns out that there are 2 variants of SMN. SMN1, which is what's damaged in spinal muscle atrophy, and then a protein in our genome, a protein that's made by our genome called SMN2. It is just like SMN1, except that when the DNA is processed, the protein that turns out is missing a piece, which we call exon 7. And as a result, it gets rapidly degraded, and only about 10% hangs around and can make up for SMN1. What the treatments, the SMOs do is, and this is the risdiplam and Spinraza or nusinersen, what they do is cause the production of, basically make SMN1 produce SMN2 by causing it to include that piece that is normally split out, that exon 7 that normally would be split out as SMN2 is processed, is maintained. And so as a result, you get the production of SMN1 from SMN2. So we call that salvage of SMN2 to become SMN1. And risdiplam and Spinraza have, or nusinersen, have really impacted significantly the course of illness and changed this from universally fatal disease to one where children are living and it becomes a chronic disease. We don't yet know long-term what's going to happen because these drugs have only been around for, Spinraza for 3 years, Evrysdi very recently, and then Zolgensma, which actually replaces SMN1. This is a gene replacement strategy using a viral vector. This has only been around about a year that it's been approved. Long-term, that real-world evidence is going to come out. We'll see what the real effect is, but we know certainly short-term, over several years, there's clearly been a major change in the prognosis of this disease, which previously was so uniformly fatal for infants. So we're very excited. Again, a home run. Moving on to neuromuscular junction, that's that communication between nerve and muscle. There are two major diseases that I'm going to mention, myasthenia and Eaton Lambert. And myasthenia is an autoimmune disease that weakness can include speech and swallowing. It can include muscles, droopy eyelids, and eye muscles. It affects 2 to 7 out of 10,000 people, women more commonly than men. There may be some genetic predisposition to develop autoimmune disease, but not specifically for myasthenia gravis. And it's very treatable. The damage, it turns out, is the production by our body of antibodies. Now, normally we produce antibodies. The immune system produces these antibodies to attack invaders. If we get a virus or an infection, we produce antibodies to immobilize that virus or bacteria and clean it up, get rid of it. In the case of autoimmune disease, those antibodies become directed at our own body. And in this case, the antibodies are directed to a receptor on the muscle membrane called the acetylcholine receptor. That receptor is responsible for translating information from the nerve to the muscle so the muscle moves. So normally, coming down the end of the nerve, there's an electrical potential. When it gets to the end of the nerve, you release a packet of chemical called acetylcholine. It floats to the muscle, contacts this receptor, and sets up a contraction. In the case of myasthenia, the receptor is blocked, so the acetylcholine can't find the receptor. And so we use medications that can keep that acetylcholine floating around longer so it can find receptors that aren't blocked. That's called mestinon. Or we use medications that suppress the immune system. And the most recent addition to our arsenal is Solaris. And Solaris actually works by blocking complement and the autoimmune reaction at that junction. However, we have several trials going on, including other drugs that will modify the immune system and modify that response. And so, if you have myasthenia gravis, look around because the rosanolizumab study, rosanoliximab study is now recruiting. So if you're interested in that, like Solaris, is aimed at decreasing the damage and the immune system attack on the junction. And this just shows you where Solaris works. This is the inflammatory cascade, and it blocks some of the inflammatory cascade at the junction. Now, Eaton Lambert is due to antibodies that attack the calcium receptor. Calcium is when the electrical potential comes down the end of the nerve cell, these calcium channels are activated and calcium rushes in to help that chemical be released into the junction and promote the communication between nerve and muscle. We have a new drug that's been approved, and that drug is Firdapse, which really blocks the potassium channel, and that enhances calcium channel productivity or calcium channel function. And so that's a new drug that's available for Eaton-Lambert syndrome. So now we're going to talk a little bit about the muscle diseases. We've moved from nerve to junction, and now we're on muscle. And of course, we're going to start with the dystrophinopathies. And everybody knows about Duchenne muscle dystrophy. This is X-linked. It's seen primarily in little boys, and it causes progressive weakness with the onset around the age of 4. Children can have calf enlargement, and as the disease progresses, and they go into wheelchairs, usually between the ages of 9 and 13, contractures form, which are stiffness of the joints, and at least before we've made some progress, there was a shortened lifespan. But we do have treatments. We now have deflazacort, which is a type of steroid, and it showed promoted longer walking and had less weight gain than the traditional prednisone, but there was more cataracts. But it may work a little bit better than other steroids like prednisone. And the bottom line is children on steroid can walk as much as 1 to 2 years longer. We now have some genetic modifiers. And again, this shows you the power of understanding the genetic abnormalities and how to circumvent them. And in this case, we have drugs, Eteplirsen, which was approved several years ago, and now Vitilarsen, which is recently approved, which actually skip over damaged areas. One targets an area called exon 51 in the gene, and the other a different area called exon 53. These are two commonly affected areas in terms of where deletions occur in Duchenne. And there are also several other trials that are exciting that have to do with gene therapy. One is actually delivering a mini dystrophin, a gene that is that codes a dystrophin that is smaller, but can still function like the larger dystrophin. And also another trial which delivers a gene that could substitute for dystrophin, a surrogate gene. So this is happening, and this just shows you the concept of exon skipping, where there's an area in purple that's deleted, and because of that deletion, it's out of frame, and everything downstream is bollocksed up and messed up, and you end up getting a protein that's rapidly degraded because it's so abnormal. Well, what exon skipping strategies do is sort of act like Scotch tape or tape, and they jump over the deleted area to the next good area of DNA, thereby enabling a reestablishment of the reading frame. So albeit a smaller protein is made, it has some function. And in both cases, the exon skipping strategy for exon 51, which was Eteplirsen, and the more recently developed Glatirasen, these are hard to pronounce. These reestablished frame, they've both shown that the muscle has increased dystrophin produced, where normally in Duchenne, when you look at the muscle, there's no dystrophin. When you treat with these drugs in the appropriate patients, again, here's where biomarkers help. You have to find the patient who has the abnormal DNA in the appropriate region. When you use these drugs, you then get some improvement in the amount of dystrophin, and at least in the case of eteplirsen, there was improvement in walking. So very exciting. Then moving on to limb-girdle dystrophy, this is really a major group of diseases. We used to lump them all together, but now we know there's autosomal dominant, autosomal recessive variants. There have been probably more than 30 genes identified associated with different variants of limb-girdle dystrophy. So step one is using that genetic biomarker to figure out which gene abnormality a person has. Because if I have gene therapy, I have to use it on the right population. So this usually, limb-girdle dystrophies cause progressive weakness. It can start, depending on the genetic defect, any from childhood to adult. They can have heart and lung involvement, depending again on which gene is affected. And previously, treatment was all supportive. We have some natural history research, as in MOVR database, going on. But we now have clinical trials in several of the diseases. There's type 1, which is dominant, and type 2 limb-girdle dystrophies, which are the recessive. And we are now looking at, in 3 cases of limb-girdle dystrophy, gene replacement. So this is not airy-fairy. This is real and tangible now. We are now in the era of using what we're learning about genetics and mechanism to cure these genetically determined illnesses. And again, it's why it's so important, if you have a limb-girdle dystrophy, to make sure you know which one you have and be part of the registry, so that when the time comes and your disease is being looked at, you can be included in those trials if you'd like. Obviously, clinical trials are voluntary. Now, myotonic dystrophy is probably the most common of all of the muscle dystrophies. It causes weakness in the hands and feet first, and then progresses. There's something called myotonia. And importantly, every body system can be involved with this disease. And it's really due to extra DNA. So it's one of those diseases where there's extra DNA. And so that one of the strategies that's being used is looking into blocking that extra DNA. And so there is some research going on in biomarkers, registry, that's natural history development, and some clinical trials of drugs. But really, there's also an interest in blocking that extra DNA. And here you can see where that extra DNA causes extra RNA to be produced. And if you can block that sort of transitional RNA, which is going to make protein using this antisense technology, you may be able to block the toxic effect of that extra RNA. And so this is being looked at in animals, and hopefully we'll see it translated to a phase 1 trial in people soon. There's been talk of it. Now, facioscapulohumeral muscular dystrophy is a dominant. It affects the face, fascio, the shoulder girdle, and then the proximal shoulders and later legs. It progresses over time. There can be heart and lung involvement. And again, there's a problem where because of the changes in the DNA, there's an increase in something called DUX4 is turned on. And so there are now strategies that are focused on decreasing that effect. In addition, we have a study of losmapimod, which is to reduce the expression of DUX4 so that it can't drive the disease. And then we have several other targets that have been looked at in the disease. So there is research. And again, I encourage you, if you have FSH, to look for a trial to enroll in. Oculopharyngeal dystrophy, again, another disease where there's excess DNA, an extra piece that results in an extra DNA becomes RNA, becomes protein. So RNA carries that information about the protein from DNA to the cell machinery where protein can be made. And here there's a strategy that's aimed at blocking that abnormal piece of RNA. And in this case, it's a little bit different strategy. DNA is delivered by a vector to make the antisense, to make the blocker in the cell, and then the blocker blocks the extra piece of RNA. So again, understanding genetics, what's happening, is going to help us in terms of treating the disease. And so very exciting. Another home run, Pompe's disease. In this case, it wasn't genetic, but we actually found a way to replace the protein that was missing. So we used something called Lumazyme, and this disease had generally, there were 3 variants, one of which was a very severe infantile onset, where children again died by the age of 2 with muscle weakness, heart involvement, lung involvement, and it's because this protein called acid maltase was missing due to the genetic abnormality. The strategy has been to replace it using Lumazyme in adults and children with the disease. We can also replace it with the same thing, but it's called Myozyme, and this has made a big difference in the prognosis of this disease. Again, showing you we're making real progress in the treatment of these illnesses, and we have to use all the tools in our toolbox. The genetic tools are becoming a reality now, and I think that's why it's very exciting. But we have other tools like protein replacement. Now, to finish off, I'm going to talk a little bit about inflammatory myopathies. And again, inflammation in the muscle is characterized by proximal weakness. You can have facial muscles are usually involved, but you can get swallowing problems. And there can be a rash in some cases. And again, we have several trials going on that modify the immune system. And I'll just point them out. There's activity here. Our treatment has been standardly prednisone and other immunosuppressives, along with physical therapy, but we have trials going on that will really are directed at the underlying cause, which is immune system abnormalities. And finally, inclusion body myositis. It may be the most frequent muscle problem over the age of 50, mainly males, but females can be affected. It occurs in older folks, and it starts with inability to make a fist and thinning of the forearm. And again, we have several clinical trials that are going on that we hope will at least be successful. Right now, treatment is generally supportive. So in conclusion, we have made real progress. And this is through understanding genetics, developing biomarkers, understanding mechanism, and developing those tools to track disease and responses, a better way to assess people, and natural history databases. And with that, I'll take questions. Thank you very much for your attention.
Thank you very much. There's a lot of therapies on the horizon. It's a very exciting time right now. Question.
And I had to cut it short.
I know. Can you elaborate on if someone can participate in more than one clinical study or clinical trial?
Why someone can't participate in more than one?
Can they?
No, you
Okay.
would confuse results. I mean, how that would really be a problem, right?
Okay.
So, we need to, if we want to get the real answer, and listen, the best way to get to the end game, which is to cure these diseases, to stop them, reversals are great. And maybe in some of the immune-mediated diseases, we'll get reversal. By the way, some of my colleagues, certainly Dr. Kwan can comment on all this too. But, to get to the end game, which is to stop the disease, and the home run is to reverse, obviously. But if I can get to second base, which is to stop the disease, slow the progression, I need good, clean trials.
Okay.
What we need to do is develop the tools to make them faster, more efficient, and get the answer sooner rather than having to wait long periods of time for survival endpoints or endpoints that take a while to develop. That's why biomarkers become so important. They may be a signal that a disease is being modified by a treatment much sooner than some of these other measures that we use.
And are there any microRNAs in
Yeah,
limb-girdle that are being studied for biomarkers?
I do believe there are, but I don't want to. I'd have.
Okay. Um, you may have touched on this, but I'm just going to ask, are there any current trials for myotonic?
Yeah, there are some current trials.
Okay.
And again, for folks, you can go on the tool that's on the MDA website to find trials near you. There's a tool where you can put in where you live, etc. You can also go, if you really want to shoot yourself, go on NIHclinicaltrials.gov, which gets to be overwhelming at times.
Okay.
And then, and you can find one near you, but there are some trials.
All right. Well, thank you. I don't see anything else that has come through in chat or Q&A. So thank you very much for your time on this Saturday. Enjoy the rest of your day.
Thank you.
Please remember we are recording these segments, so they will be available for viewing later. We're going to take a quick break and we'll be back. Thank you.